angioplasty, and then you place a stent. And that all is collectively referred to as PCI. And so the question is, okay, who needs to go to PCI? Does every single person with chest pain and an abnormal ECG need to go to the cath lab and have a PCI? Well, clearly not, right? Because if that were the case, you would basically have, I don't know what percentage of a population of the city that you're working in lined up waiting to go into the cath lab, and a lot of them don't need to go, right? So we need some way of figuring out who, it's a triage, a way of triaging people essentially, right? I mean, we can't just send everybody with any sort of complaint that might be cardiac in nature in some sort of ECG anomaly to go to the cath lab, right? So we need to figure out, okay, who needs to go and who maybe doesn't need to go at all. And maybe they need to have other tests, you know, like a stress test or something like that. Or maybe they need to go to the cath lab in the next day or so, right? Figure out who needs to go right away and who can be delayed. And that's a big part of where we come in, EMS, right? Because one of the major tools we have at our disposal is the 12-lead ECG. So we have signs and symptoms, clinical presentation, vital signs and all that, and our laboratory data, i.e. the ECG. When we put that together, and that can help us make an initial decision on where people need to go. So the ECG, the interpretation of the ECG is actually really important. And that's what we're focusing on primarily here today. All right. So hopefully everybody's good there. And I suspect that this is a review. Okay. So that's where we're at. So for a long time, we have been taught that STEMI patients, all right, and I want to talk to you about what STEMI looks like. Okay, so we're going to talk about that. Right now, I'm just building up the intuition for where we're at, right? So this is going to be more conceptual. So the thinking is, and I'm going to explain where all this comes from. And this is maybe something that people don't do when you learn ECG interpretation. You don't actually take a class or have a lecture that talks about, well, how in the hell do we actually get here, right? But what we've been taught is that if there's STEMI, if there is a certain pattern of ST elevation on the ECG, this is the quote unquote bad heart attack, and this needs to go to PCI immediately, right? And then there is a whole other group of patients that don't have this ST elevation, and we call those NSTEMI/USA. NSTEMI stands for non-ST elevation / USA stands for unstable angina. And these are patients who can be delayed. All right, they're not as critical. And NSTEMI/USA is not as quote unquote bad as a STEMI, right? It is a mild or a minor heart attack. That's what we have traditionally been taught, right? Is that you've got an acute coronary syndrome, and it generally falls into one of two major categories. All right. And we've been taught that the NSTEMI patients were not as bad, and typically they could receive medical management, all right, while they're waiting to go to cath lab within the next 24 to maybe 36 hours or so, right? And medical management includes anticoagulants, right? So we can give them heparin, we can give them nitroglycerin, put them in nitro drip, we can give them P2Y12 inhibitors, and so on and so forth. And then they can go to cath lab in the next day or two. All right. So that's where we're at. Okay. So what I want to do is I just want to talk about the history of where we got to where we're at today. And it really started, in the 1970s and the 1980s. And there were experiments that were done with streptococcal bacteria. And I think I mentioned this in pathophysiology. And streptococcal bacteria can release exotoxins. And one of these exotoxins prevents blood from clotting. Or actually, what it does is it doesn't prevent blood from clotting per se. It actually breaks clots down, right? It causes essentially the fibrin clot to get converted back into fibrinogen. Fibrin gets converted back into fibrinogen, and then you have lysis of that stable fibrin clot. You have fibrinolysis, and these have been called fibrinolytics because of that. A vernacular term that is commonly used is thrombolytic, and I've explained back in pharmacology why I don't prefer to use the term thrombolytic, because it's really a fibrinolytic, but a lot of people use that term, and so we kind of know what it is. And the landmark research that cemented fibrinolytic therapy, so fibrinolytic therapy was originally the standard of care for patients experiencing acute myocardial infarction. And this was the GISSI-1 trial, GISSI-1, which is it was a group of Italian, I believe it was a group of Italian researchers, and they published their study in the Lancet, the journal Lancet, in 1986. All right. And this was the landmark trial that showed that fibrinolytics or thrombolytics could effectively reestablish blood flow in somebody experiencing acute coronary syndrome. And there were many thrombolytic or fibrinolytic trials that were completed in the 1980s and 1990s. This is absolutely mind-boggling to me, right? That about the time I was born, around the time I was born, we did not have good way of managing myocardial infarction. In my lifetime, we went from, well, hopefully you survive your heart attack and you're not too disabled afterwards, right? From that way of thinking to where we are now within my lifetime. And I'm not super old, but it's just astonishing that this is an area of medicine where we have made immense advances. All right. So there are many trials done that looked at providing reperfusion therapy with fibrinolytics. And these were well-done studies in a certain extent, because they actually had placebo controls. And so they were actually taking patients who were having heart attacks, and they were giving them fibrinolytics, and then they were taking the other group of patients, and they were just kind of giving them whatever the standard of care at the time was. And it was just like an immense number of people getting fibrinolytics just did so much better. All right. Now, we don't actually have placebo-controlled studies for some of the new stuff that we're doing, like with PCI, with the cath lab, with coronary intervention. And the reason being is that PCI is just so effective that it would be morally and ethically dubious to take a group of people that you know are having a bad heart attack and say, I'm not going to give you a cath because I want to compare you to the people that are getting stented, right? It would just, you could not convince an institutional review board to sign off on that study because it is just so plainly, amazingly effective that we just can't do these large placebo-controlled studies with PCI. It would be deemed ethically and morally dubious. But anyway, these trials in the 80s and 90s enrolled patients that had symptoms of acute coronary syndrome and ST elevation. All right. They're like, well, what's some common finding that we see in patients that are having these big heart attacks? Oh, ST elevation. Okay, well, they have ST elevation. Let's enroll them in this trial. All right. Now, there was a high degree of variability as to what people considered ST elevation back then. Like, what was the threshold that we used to determine who is going to get enrolled in this trial? And it varied quite a bit. All right. But at the end of the day, the trial showed benefits in ST elevation with people who receive fibrinolytics versus placebo. Okay. And again, that the landmark trial was the GISSI or GISSI-1 in 1986. There were several other trials. There was ISIS-2 in 1988. There was the late trial in 1994. And then there was the TIMI-3B, the TIMI-3B trial in 1994. This is actually where the the term TEMI, blood flow, kind of came from out of these early trials. In addition to that, these trials also looked at ST depression. All right, so you have elevation of the ST, and I'll talk about what that looks like. All right, we're just building the foundation right now. But we also looked at ST depression, right? So Jesse 1, ISIS 2, late, TEMI 3, they all looked at ST depression. All right. And what did we notice? Well, we noticed a couple of things. We noticed that patients that had ST depression did worse. Okay. They did worse when they got fibrinolytics. And it was this that kind of led to our current understanding of, or our current way of managing heart attacks. Oh, so people that were having ST elevation did better, and people that are having ST depression did worse, right? And so at the time, it looked like people that were that fell into that in STEMI category back here, right? If we tried to open up their coronary arteries, they did worse. They had worse outcomes. And so why would we push for fibrinolytics? Why would we push to get them into the cath lab right away? Because they do worse, right? And so that cemented this idea that the STEMI patients needed to get fibrinolytic therapy and the in-STEMI patients did not. All right. But there were some problems. There were some problems. So the problems included a couple of things. Very small numbers of patients with ST depression were enrolled in these studies. Okay. And often the only thing that was used to enroll somebody was 1 millimeter of ST depression. Right? So they had 1 millimeter of ST depression, and in many cases, it was just one single lead. So if you saw 1 millimeter ST depression in one single lead, we enrolled that patient, these small numbers of patients, and we gave them fibrinolytics and they did worse. And therefore, 20, 30 years later, all patients with ST depression do poorly. That was the kind of thinking, right? And then another problem, all right, and this is a big one. Very few patients with ST depression receive fibrinolytics in less than 6 hours. This is a big one, all right? So we know that if you're having a bad heart attack, you need to have reperfusion immediately. The sooner the better, right? Current cath lab, and you can get a balloon opening up their coronary artery within 90 minutes. That's like the gold standard, right? We call that door to balloon time, 90 minutes. Or if you're going to be delayed, if there's some delay in getting somebody care, maybe they're way out in a small outlying hospital and it's going to take hours to transfer them to a cath lab, they need to get fibrinolytics within 90 minutes. So we are still using fibrinolytics today. It's just that we're using fibrinolytics if we can't get somebody to a cath lab in a reasonable amount of time, all right, within about that 90-minute window. So that's the standard, right? 90 minutes, door to balloon, 90 minutes, door to drug. And I'm telling you that most of the patients that they looked at in these trials with ST depression that would fall into, if they have ST depression, they don't have ST elevation. So they would fall into the in-STEMI paradigm, right? We would call these in-STEMI patients nowadays. All right. And very few people with this ST depression with in-STEMI receive fibrinolytics in less than 6 hours. In fact, in the TEMI 3B trial, the median, that's the middle, enrollment time was 9 hours. So these patients sat in the hospital on average in this trial, on average for at least 9 hours before they were given fibrinolytics. And then they published and said, oh, people that get fibrinolytics that have ST depression, that have STEMI, do worse. So let me ask you all a question. Why are these patients doing so much worse? What do you all think? When we look at the data, why are they actually doing worse? What do you think?
Delay of care.
Exactly. It didn't really have anything to do with the fibrinolytic therapy per se. It was the delay in care. Right? Delay in care. Yeah. We were letting them sit, they sat and had a big MI for 9 hours before we did anything about it. Of course they're going to have bad outcomes. All right. So that was one thing. The other thing is that most people thought that STEMI, untreated STEMI, would have worse outcomes, right? So we would say that STEMI is worse. So STEMI is worse. It needs to go to the cath lab. All right. Well, let's look at some additional data. All right. There is research that shows people with STEMI, with ST depression, have high rates of mortality. And the big trial that looked at this was the Gusto 2B trial. I believe this was done in 1998. So this is a bit more contemporary. We're going to the late 90s. And it showed that patients that had with ischemia and ST depression of 2 millimeters or more in 2 or more leads. So they actually had a consistent way of describing ST depression, or what we would call STEMI today. And they said, okay, if a patient's having signs and symptoms of acute coronary syndrome and they have ST depression of more than 2 millimeters in 2 or more leads, that's what we're going to consider an STEMI. Okay. And so what they did is they looked at those patients. All right. And they looked at mortality. And patients that had this ST depression in the Gusto 2 trial had about a 14% rate of mortality versus people who did not have depression. So maybe they had ST elevation, for example, and so no ST depression, they had about a 4% rate of mortality. So clearly, we're starting to see, oh, you know what? STEMI patients, STEMI may be bad. This may not be as benign as we'd like to think. Well, that was 25 years ago, you say, right? This 1998. That's when Chris was. Let's see, 1998. I was in pre-nursing. I was a pre-nursing student, right? I was taking my first anatomy and physiology class in 1998. Clearly, things have changed, right? We have more contemporary data. We actually do. We have data from studies done in 2015. That's a bit more contemporary, and it actually looked at 1-year mortality. And it looked at, I believe, what's known as all-cause mortality, which is just any cause of death in 1 year. All right. And they compared STEMI to STEMI patients. Like, okay, well, let's look at the mortality rates. And they looked at 1 year, and they also looked at 5-year mortality rates. All right. So STEMI versus STEMI. 1 year mortality rates in STEMI was about 9.9% in the STEMI group versus about 18.1% in the STEMI group, right? So double the mortality in the STEMI group. And then at the 5-year mark, they looked again, and we saw 16.4% in the STEMI group versus 33.7% in the STEMI group. All right. So guess what? STEMI can be as bad, if not worse, than STEMI. What we think is going on is that it may not be that in-STEMI is inherently worse than STEMI. It's just that we tend to delay care in STEMI patients. And so we think that really it's the delay in care that's the problem, all right? And this data, this delay in care when it comes to in-STEMI, treating in-STEMI patients differently than STEMI patients, we've reproduced these findings in more contemporary evidence. There was a study that was just presented in Paris in the last couple of weeks. Dr. Herman et al. Looked at this and they saw poor outcomes in occlusive acute coronary syndromes in patients that were not having ST elevation, so they're having in-STEMI, all right? So hopefully everybody's on board with the fact that in-STEMI can be as bad, if not worse than STEMI. And that hopefully you all agree with me that I've presented a compelling argument that STEMI and in-STEMI can be bad, right? They can both be bad, and they both, right, require treatment, sometimes immediate treatment. And that if we delay treating some portion of these in-STEMI patients, we do that at our peril, right? And their outcomes, if they don't get treated appropriately, the outcomes can be worse than actual STEMI patients. Okay, so I do want to just spend a little bit of time talking about PCI and the history of PCI. So PCI came around about the same time that fibrinolytics were being developed. The very first PCI was actually performed in 1977. So around the time I was being conceived and born and all that. It was performed in Switzerland, actually. Now, PCI did not become widely available and accepted right away, but by the 1990s, it was becoming much more accepted. So the very first one, it was actually two of them that were done in 1977, and they were fairly successful. And then it kind of, the momentum kind of built from there. And at that time, what was done was not what we do today. It just required, at the time, all they did was balloon angioplasty. So all they did was they opened the artery up with a little balloon, and that was it. And then they ended up incorporating metal stents, like fully metallic stents later on. And then we did some research on this in the 1980s and 1990s. All right. And we found that with balloon angioplasty, about 30 to 50% of patients that had balloon angioplasty would have restenosis. The artery would reocclude. And then this led to the development of newer stents, right? So stents were used, but these were fully metallic stents, full metal stents. And they had pretty high rates of restenosis or occlusion. And so what happened was in the 2000s, newer, what we call drug-eluting stents and stents made of other materials other than metals were produced. And that's kind of where we're at now, is we're using the newer generations of drug-eluting stents, and that markedly decreased the restenosis rate. And currently, PCI is a preferred reperfusion therapy over fibrinolytics because fibrinolytics often do not achieve normal coronary blood. So you give a fibrinolytic and you can reestablish some blood flow, but oftentimes you cannot get to TEMI-3 blood flow, right? Which is normal blood flow, but you often can get TEMI-3 blood flow using PCI. Now, there are no large randomized controlled studies of PCI, just because the benefit appears to be so great. Like I mentioned earlier, it would be ethically dubious to deny anybody this therapy. So this is the standard of care. All right, so that's where we're at now. All right. So these initial studies led to kind of our contemporary belief that STEMI requires immediate cath lab activation. However, as we described earlier, STEMI patients can have as bad, if not worse, outcomes than STEMI, right? So in STEMI, as bad, if not worse outcomes. Most of that is probably due to delay in care. Okay. And two, this is important, and this is actually something from the difficult study. The difficult study that was published in 2020. And they found, and this is kind of the nail in the coffin for me, they found that 25 to 30% of in-STEMI patients had total coronary artery occlusion when they went to the cath lab. All right. I just let that sink in. Almost a third, 1 out of every 3 patients who have in STEMI have a total occlusion of the coronary artery. So that means that a third of those patients that fall into that in STEMI category need to go to the cath lab. And this paradigm that we use, going back here, oops, going back here, right? So STEMI, cath lab immediately. In STEMI, let's sit on you for a day or so and then send you to the cath lab. All right. 1/3 of these patients have total occlusion of their coronary artery. So a third of these patients are falling through the cracks. All right. So I really want that to set in. Finally, we've seen some official movement. Back in October, so this is October of 2022, so just a few months ago, 6-7 months ago, the American College of Cardiology, the ACC, released guidelines that said there are certain problems, there are certain ECG findings that are equivalent to STEMI. So they said, hey, you know what? If somebody falls under the umbrella, if they fall into the STEMI paradigm, they need to go to the cath lab immediately. But there are 4 additional things that we are going to call a STEMI equivalent. That is to say that they're equivalent to a STEMI. Okay, and these included the following 4 things: posterior MI, De Winter T waves, 3 hyperacute T waves, and 4 positive Scarbosa criteria. Okay, so these 4 things are considered equivalent to STEMI and should go to the cath lab. All right. And this is not just, Chris and just kind of some cool stuff I want to throw at you. This is the American College of Cardiology, right? Consensus guidelines based on the currently available evidence that they're saying this. Okay, so before we head into our first break, while an advancement, this is still, I believe, a bit incomplete. So there is a new paradigm emerging. And this paradigm really began in 2017. And 3 physicians published a manifesto of sorts. It's actually called a manifesto. It was Dr. Smith, Dr. Weingart, Smith, Weingart, and who is a third physician? there's one more, Smith, Weingart, and another gentleman, Smith and all, we'll say, published something called the OMI, or the OMI Manifesto. The OMI Manifesto. All right. They published that. And they said, look, we need to stop looking at this as in STEMI versus STEMI. All right. So the traditional way of looking at things, all right, is you have signs and symptoms that suggest an acute coronary syndrome. We do a 12-lead ECG on you, and if it shows STEMI, you go to the cath lab, right? Immediately go to the cath lab. If it shows in STEMI / unstable angina, right? Maybe in 24 to 36 hours, you go to cath lab. Okay, that's kind of what most people are working under. So what they proposed is a new paradigm where you have acute coronary syndromes and you have two manifestations of an acute coronary syndrome. You have something called an OMI or an OMI, and OMI stands for occlusion myocardial infarction. An occlusion myocardial infarction is where you have near or total occlusion of a coronary artery where you do not have sufficient collateral circulation and you have active infarction. So near or total occlusion of a coronary artery with insufficient collateral circulation that causes active infarction. That is an occlusion myocardial infarction. All right. And then a NOMI is a non-occlusion myocardial infarction where you have sufficient collateral circulation to avoid active infarction. All right. And then what we realized was there are actually several things that can be considered OMI. For example, STEMI. The classic STEMI is considered an OMI. Okay, no doubt. But there are many other things, right? There are many other things like posterior MI, like De Winter T waves, all right, like hyperacute T waves, like positive Scarbosa criteria, okay, like let's see here, something called South African flag sign. All right. So OMI is a much more inclusive way of defining this. And OMI also does not differentiate STEMI by itself. OMI says STEMI is a type of OMI, right? But there are many other things where you can have total occlusion other than STEMI. And so some of these other things here that present with something other than ST elevation are captured. And so what we're trying to do with this is we're trying to capture that 25 to 30% of patients who have been falling through the cracks. All right. And so I want to conclude with that in mind, that is where I want to focus, is I want to be much more broad in how I look at this. And I, unfortunately, am going to require that you all be much more broad now, and that we're going to expand beyond STEMI, right? We are definitely going to talk about STEMI. In fact, that's primarily what we'll be talking about today. But I want you to understand that STEMI is just not its own thing. STEMI is just one thing under the umbrella of OMI, right? You've got OMI, and then STEMI is one type of OMI. De Winter T waves is another type. Hyperacute T waves is another type. So there are many things under the umbrella of OMI, and it's not STEMI that needs to go to the cath lab. It's OMI. If you're having an OMI, you need to go to the cath lab, and a STEMI is one type of OMI, but it's not the only type. All right. And if we can kind of rewire our thinking to that paradigm, we will be able to capture more people, and we will be able to prevent a significant number of death and a significant amount of morbidity and mortality potentially. All right. So before we conclude this first lecture, are there any questions? Okay, well, it's 9:45. Let's take a good break. I'll see you all back at 10, and then we'll dive into 12 lead ECG interpretation.